Hi, everyone. We'll plan to start in just a couple minutes, just to leave some time for anybody who's coming in late. I'm gonna keep the chat box open in case people want to send messages. Is it blocking the screen for anyone? Oops, sorry. Okay. Thanks, Reem. Just gonna try to open the thing again. Oops. I don't know how to, oh, there we go. Okay. We'll just give it another minute or two to see if anybody else comes in. Is everybody able to open the quiz? Great. All right, it's a couple minutes past 7:30 Central Time. I'm on Eastern Standard Time, but I know everybody's coming from all over the place. Nice to meet you all. My name is Jackie. I am I'll have an intro slide coming up next, but as you can all see, we're going to be talking about endocarditis today, which is a personal favorite topic of mine. So we'll just hop into it. So this is just a little bit about me. This is a picture of me with my team last year when I was an intern. I studied biochemistry and molecular biology at the University of Miami in Florida. I got my MD from Nova Southeastern University, also in South Florida, and now I'm up at Mount Sinai in New York City. I'm a second year in my internal medicine residency. And I've been with Motivate MD since my second year of medical school, which has been really fun. So I've been with them for maybe 4 or 5 years now. So I'm just going to go through kind of the structure of this presentation. For those of you who haven't been here before, I apologize if you have. So we're going to go through a case together. We're going to go through the physical exam. We're going to develop a differential. We're going to talk about the assessment and plan for that patient. And then we're going to talk a bit about, in this case, endocarditis. There's only 5 of you guys here. So again, safe space. There's no stupid responses, no stupid questions, but I feel that you will learn best if you actively participate. I'm going to leave the chat open here on the side, so you're welcome to send messages into the group, or you can message me individually if you don't want the other group participants to see your answers, but I encourage you to just kind of throw everything out there. I'm going to ask a lot of questions, and if no one responds, then we'll just sit in silence. So you'll learn best that way, I think. So please fill out the note as you go. Let me know if I need to speed up or slow down. And then there'll be a short quiz at the end of the case, and then I'll answer any questions that you guys have. This is what the SOAP note looks like. Just to quickly go through it, I didn't know what a SOAP note was when I started medical school. So quickly, let's just go through what kind of things would you go in the subjective portion of the SOAP note. Anyone? Yeah, I know it says right there, but so basically the subjective portion, and this is really relevant, this is how we present in the hospital as well, is anything that's said directly by the patient. So exactly, Mohammed. So symptoms, things that the patient is describing. So this would be, oh, I came in with abdominal pain for the past 4 days, and I've been vomiting, and I've had a fever. So that would all go in the subjective, and that would even include like my family history, the medications I take, surgical history. Now we get into the objective part of the exam, which is not things the patient is directly telling you. Rather, these are data points that we collect from the patient. So where in the subjective portion, they might say, I have abdominal pain. In the objective portion would be the physical exam where I say, this patient has tenderness when I press on their abdomen. That would be an objective finding. So sometimes you'll have patients say, oh, my stomach hurts like crazy. And then you go and press on it and they're not flinching or wincing at all. And so sometimes those things don't line up. And then finally, we get to the assessment and plan. So assessment will be where we kind of summarize everything that from their story and then the data that we've collected. And then, of course, we develop a plan for it. So here is our patient. This is a patient that I actually saw in the hospital too. Obviously no names because HIPAA, but this is actually a patient that I saw, so that's kind of fun. He's a 43-year-old male presenting with progressive fatigue and fever over the past 4 days. His symptoms were associated with a decreased exercise tolerance. He's now only able to walk about 1 or 2 blocks without having to stop. And he's also got some sharp, non-radiating chest pressure. Someone just give me a thumbs up when we're ready to move to the next slide. I can always go back to this at the end too. All right. I'm going to click next, and then we can always come back to it at the end. So what are some questions that you would like to ask this patient, given that kind of background that we got from him? You guys can start throwing out the questions. Medical history, sure. Rate the pain, good question. So I'm going to answer as if I'm the patient. So as far as the medical history, this is kind of a younger guy. He's like, nah, I don't have any medical conditions. He doesn't have a primary care doctor, doesn't see anybody. He thinks he's perfectly healthy. So he's like, no, I don't have any medical history. As far as rating the pain, he's like, oh, it's not really that bad. But it has kind of caused him to have some difficulty and completing his daily activities. He might rate it as a 5 or 6 out of 10. Good questions. Any other questions? You're like at the bedside with the patient. Trauma. Yeah, he doesn't endorse any trauma. That's a good question. So when someone comes in with pain, it's good to ask, like, how did the pain start? He doesn't say he has any. What kind of drugs? He says heroin. He uses a bag of heroin per day. And he injects them. Or the heroin, rather. Any other questions you want to ask? When was the last time he used? Good question, Reem. He used last right before he came in. Any physical exam findings that you want to look for? Anything specific on the exam? We'll go through the exam together in a minute. Does he take any medications? No. He says he doesn't take anything. He says he's perfectly healthy, doesn't take any medications, which is what he told me. Did he take the drug in a different location than usual? That's a good question. No, he usually injects into the arm. He's got track marks all up and down his forearms. Has he done anything to alleviate the pain? Maya, that's a great question. So when someone comes in with pain, we like to ask what makes it worse and what makes it better. So to alleviate the pain, he says, sitting down and kind of catching his breath sometimes helps a little bit, but it will just kind of go away on its own for the most part. That's actually a great question as well, because especially when we're talking about the heart, certain types of chest pain are more concerning for things like heart attack. Like if it's worse when you're walking up a flight of stairs, say, we call that exertional chest pain. He says that the pain isn't necessarily exertional. It can kind of happen at any time. He has experienced symptoms like this before. And it's prompted him actually to come into the hospital, but he'll usually leave against medical advice and he won't stay for a complete hospital course. So here's some more details about him. You guys asked some really good questions. So usually, like when I'm in the hospital and I get a new patient, you can go back through their medical records and see some of their prior hospital admissions. So when I was reviewing him, I saw, okay, he's been to the emergency room, 4 or 5 times in the past year or two, all for similar things. He's short of breath. He's got this kind of non-specific chest pain. And then they try to admit him to the hospital for workup, and he leaves against medical advice. So we're not really able to see much of the workup for him. He's got this history of IV drug use for about the past 15 years. He smokes. We use this metric called pack year history when we talk about people who smoke. And pack year history helps us to determine risk, basically, of like developing lung cancer and things like that. And so 1 pack year would be equal to 1 pack of cigarettes a day for a year. So 10 pack years could either be 1 pack of cigarettes a day for 10 years, it could be half a pack of cigarettes a day for 20 years, etc. So I don't remember what his exactly was. Sometimes they'll say like, oh, 4 or 5 cigarettes here, and then you have to do some kind of annoying math. He doesn't use marijuana, cocaine, and says he also doesn't drink any alcohol. He doesn't know his family history. He's like, oh, I don't know them. And surgical history, he denies surgical history. Any other questions that you want to know about our patient? All right, we will keep pushing forward. So here's his physical exam. We're looking at some vital signs here. I just want to make sure you guys know the normals. Does anyone know the temperature that qualifies a fever by definition? It's okay if not. These are all things that I learned in medical school. It is 100.4. Yeah, it's really close. It's really specific. It's 100.4. So this would definitely be a fever. Does anyone know the normal range for heart rate? It's okay to guess too. 80, yeah, 80 would be a good normal number. 70 to 100 would be a little tachycardic. Usually we say 60 to 100. So that's actually a good range, Maya. 60 to 100 is usually what we use. So he's definitely, we would say febrile. We would say he's tachycardic as opposed to bradycardic, which means your heart rate is lower than 60. Respiratory rate, he is breathing quite fast. About 16 to 18 is normal for like you or I. Blood pressure, we like this to be like 120/80, so he's a little bit hypotensive. O2 saturation should be in the high 90s, but he's on 5 liters nasal cannula, which is that little tube thing that goes into the nose. So looks kind of like a sick guy. He's tired appearing in the stretcher. He's kind of leaning forward, looks pretty uncomfortable. Cardiovascular system wise, as we said, he's tachycardic, can hear his heart beating really fast, but the rhythm is regular. We hear this decrescendo diastolic blowing murmur at the left lower sternal border, which we can talk about what that means in a bit. I think I have a picture of the chest wall somewhere. We listen to his lungs and he's got some crackles noted at the bases of the lungs. The abdomen is soft and non-tender. He's got pitting edema in the legs, which I'll show you guys on the next slide. Neurologically, he's alert and oriented ×3, meaning alert to person, place, and time. So you would say like, what's your name? And you'd say Mr. Smith or whatever. Do you know where you are right now? Oh, I'm in the hospital. And do you know what year it is? And then they would say 2024. You get some pretty wacky answers from people who are not alert and oriented. Cranial nerves 2 through 12 are intact. No focal neurological deficits. He has some scars and scabs on his arms, which are his track marks. And also on the legs and dorsum of the feet. Someone asked if he's been injecting other places recently. He said no, but then sometimes that's why the subjective and the objective sometimes don't line up. So this is just a quick little thing. So when we listen to the heart, I don't know if you guys can see my mouse or not. This chest wall over here, these are the names of the 4 valves: aortic, pulmonic, tricuspid, and mitral. We'll talk about them in a bit later as well. This is the sternum here. So we stay like at the upper sternal border, would mean like at the border of the sternum up at the top. Here we would say this is at the lower sternal border. And here we'll say is at like the apex of the heart, because the heart sits like, again, I don't know if you can see my mouse, the heart sits here. So the apex is here at the tip and the base is here, which is kind of not intuitive. You would think that the base would be towards the bottom, but the base of the heart is actually over here. So he had this decrescendo, can I go back? Decrescendo diastolic blowing murmur at the left lower sternal border. So that would be right here. We heard a diastolic blowing murmur, and diastolic and systolic are the two, it's the lub dub of the heart. So systole being when the heart squeezes the blood out, and diastole being when the heart relaxes and fills back with blood. Pitting edema is in these pictures. We grade it, but people kind of don't really grade it accurately sometimes. They'll just say pitting or non. And so it's literally when you press into the skin, it will leave a little indent in the leg. And this is part of the physical exam that we'll do on most patients. And pitting edema means that the fluid that should be in your vessels has gone outside of the vessels and is kind of filling up the tissue. And so when you're pushing in, it's like leaving an indent and like a sponge, you can think, filled with water. And so it means that he's kind of leaking excess fluid into the legs. You'll see this is a very common physical exam finding. Some people who just have poor vasculature will have this, and it's common in some other pathologies we'll talk about as well. So now we're going to start developing a differential diagnosis now that we've gotten some history and some physical exam on him. So let's start throwing out, I put some categories here. What are some things that we're thinking of? Don't say endocarditis because that's what the talk is about. What else do we think could be cause for his symptoms? Heart failure. Yeah, really good one. So he's got this new murmur. He's got this pitting edema in the legs, which is actually a pretty strong sign of volume overload, which we see in heart failure. And also he's got some crackles in the lungs, which means that he's got some probably fluid in the lungs, which is also seen in heart failure. Great. Lung embolism. Yeah, I was thinking that too. So anybody who's tachycardic, meaning their heart rate is kind of elevated and having a difficulty breathing, thinking of a pulmonary embolus or a clot in the large vessels that supply the lungs is a great differential. Reem, I think that's a good one too. Myocardial infarction. He's got this new murmur, which we can sometimes see. He's got this chest pain that he can't really describe. I would definitely consider that on the differential. That's one that we shouldn't miss. Angina, yeah, angina is a good one. That falls into a couple categories. We have like typical and atypical angina, which kind of corresponds to when we see the symptoms. So like I was saying before, things that are like heart attack concerning, we use 3 criteria for cardiac chest pain, and those are also typical chest pain, which is it exertional? Does it resolve with rest or nitroglycerin? And is it substernal and pressure-like? And so for him, it wasn't really exertional. He said it kind of resolved with rest, and he's not really able to carry. Oh, he said it was sharp. So it's not quite cardiac, but I think that that's also a great differential. Overdose is a good one. I think it's definitely something to consider with the drug history. Typically, a heroin overdose is going to look kind of like you're kind of zonked out. But definitely I'd put that on the differential and I would watch him for withdrawal symptoms. Anyone else? These are great answers, everyone. Cardiomyopathy, yeah. So there's a bunch of types of cardiomyopathy. There's like dilated cardiomyopathy, there's hypertrophic cardiomyopathy, but definitely something's going on with the heart for sure. Whether it's too big, too thick, if it's infectious. But I think that that's a great broad category for him for his symptoms. Anything else before we move on? You get some more data. This is how it works in the hospital. Like they'll let you know that you have a patient admitted, and then you'll go and you'll chart check them. This guy like didn't have very much stuff. Then you'll go see him, and then you kind of start developing your differential. And then I go back to my workroom and I start putting in orders. So this is very much the flow of how this would happen to us in the hospital. So these are just some broad ones that I kind of came up with. So I think that you could consider a pneumonia for him. He does have a fever. He does have this new oxygen requirement. He's kind of short of breath. I would definitely consider that. Pericarditis, the pericardium is that like thin sac that kind of lines the heart and lets it beat in the chest kind of fluidly. Sometimes that sac can become infected. And so that would be pericarditis, which classically can cause kind of positional chest pain. So like you'll see those people, if they lie back or lean forward, the pain will get worse or better, which is very characteristic of pericarditis. Someone said heart failure already, which is great. I put pericarditis here too, because it's also cardiac. Endocarditis, of course. Thank you for not saying it. Myocarditis, which is infection of like kind of the heart muscle itself, which is different than endocarditis. And acute MI. People said myocardial infarction and angina, so I think those would kind of fall under there. People said pulmonary embolus already, Maya. And then asthma exacerbation, I just kind of threw out there again because he's like having some trouble breathing. So now we have him, we're back at the workstation and we're about to put in some orders. What kind of data do we want from him? What blood work do we want? What imaging studies do we want? How can we start narrowing down our diagnosis? Based on what we think it most likely is. Don't say endocarditis. Chest x-ray, yeah. If this patient came to you from the emergency department, they absolutely had one done already because they order them on everybody. So we'll look at his chest x-ray for sure. Echocardiography is a great one. He's got these weird kind of cardiac symptoms. Sounds like his heart's probably not pumping very well. Definitely want to get an echocardiogram to look at the valves, look at how big the heart is, look at the pumping function. Absolutely. Yes, absolutely, Annabella. We will want a CBC to get a complete blood count, and we'll be looking right at those white blood cells to see if he's got an infection. Any other data that we'd want from him? Could do a CT scan if I definitely thought that it was like a pulmonary embolus, meaning that clot in the lungs. We have to do a CT scan of the chest with contrast dye. So that will actually kind of highlight the clot in the vessel. And so if I had a high suspicion for that, I absolutely would order that CT scan right away. We would do, yeah, you know what? For him, I would do urine drug testing, just to see because unfortunately, I don't want to stereotype, but a lot of people who use one drug use multiple drugs. And so I would probably want to do a urine toxicology on him and just see what else was in his system. And that's helpful because like say cocaine intoxication, which he said he didn't use, can cause like a vasospastic angina and cause like the vessels in the heart to contract and it almost looks like a heart attack. So things like that can be helpful for sure. I think he just had opiate in his system, but it's always good to check. And honestly, I get them on people that I even give me kind of a wacky story just to see. And you'd be shocked what comes up. Anything else? All right, let's see what else we got here. Labs, imaging, other. All right, let's see what we got. Okay, so these are the labs that we got for him. I don't expect you to know what these three are here in the middle. But here we have, this is the fishbone diagram, which when you're in the hospital, you'll learn all of these values. This is not high yield for you to know right now. But this gives us a snapshot of his electrolytes on top. This is his BMP, basic metabolic panel, and his CBC, his complete blood count. So here, I'm going to just go ahead and say there's nothing significant really here on the BMP. And the main things that I'm looking at here, if this is my patient, are the potassium is really important because if it's high or low, that can predispose to potentially fatal arrhythmias of the heart. So I'm always paying attention to this value. And this value right here, the creatinine, is kind of a surrogate for kidney function. And so I'm always looking at this too to make sure that he's not like going into some sort of kidney failure direction. Now this is what we really wanted, the CBC. So someone tell me what does this tell us? I put the normals on the side for us. Infection. Yeah, we see a high white blood cell count, which can be caused by other things, but I think in his case, with the fever and everything, I would definitely say this points towards infection. So now I'm thinking things that cause infection, maybe pericarditis, maybe endocarditis, maybe pneumonia, something kind of along those lines. He is not anemic right now. His platelets are fine. That's really the only thing we see. Now, these values in the middle are things that I would always get on someone with kind of a concerning cardiac history. Troponins is the value we use when we're like, oh, I think this person is having a heart attack. But basically, troponin is kind of like a protein that's released by the heart when it's stressed out. And so when we see these numbers in a person with an acute MI, they'll be in the thousands. And so we kind of will look at these numbers, and the assay is so sensitive now that like if you were to run really hard or like do a big workout at the gym, you might have a little bit of a troponin spike. Obviously nowhere near if you were having a heart attack, but just your heart kind of stressing itself out will leak a little bit of these enzymes. And so this for him is not a very large number, but the most important thing is to look at the trend. And so it actually went from 46 to 44 when we repeated it a few hours later. And so that tells me that he's probably not having an acute heart attack because those numbers would be going up, up, up over the next few hours. The BNP is the brain natriuretic peptide, and although it says brain, we actually use this to tell us how this is kind of a surrogate for does this person have a heart failure picture or not. Again, in someone with acute heart failure, this number will be in the thousands, but for you or I, who do not have heart failure, I hope, the numbers should be quite low. So this is kind of like a maybe higher than you would expect for a 40-something-year-old, but not like florid heart failure where like his heart is barely pumping. And then we drew blood cultures, which is where we just take the blood and we incubate it and we wait to see if any bacteria, fungus grows. And those take a couple of days, unfortunately. So we drew them and now we're just kind of waiting. We got an EKG on him, which I don't expect you guys to know how to read because it's a whole thing that I could go on for hours about. But essentially the EKG gives us a snapshot of what the electrical conduction system of the heart looks like. Does anyone just want to throw out what are some things that we use the EKG to look for? You can be really broad. Dysrhythmia, yeah, and I like that you said dysrhythmia, not arrhythmia, because arrhythmia implies that there's no rhythm at all, which I hate. Dysrhythmia, yeah, meaning that the heart is not beating appropriately at an appropriate rhythm. When we describe the heart, we usually say regular rate and rhythm. Regular rate being that 60 to 100, and regular rhythm meaning each of these peaks corresponds to one beat of the heart. In something like atrial fibrillation, for instance, that is classically called an irregularly irregular rhythm. So these lines would be at all sorts of weird intervals from one another. Great. Anything else we can tell from an EKG? I'll say the big one. We get an EKG to see if someone's having a heart attack. You can tell one side or the valves, not as much. It would kind of be a little bit of a jump, but I like where you're going with it. Sometimes if someone has like a really stenotic valve, then chambers of the heart will kind of like blow up. Not blow up, but they'll like get bigger, and you can kind of see evidence of that on the EKG. So I want to say kind of yes. The better study for valves is an echocardiogram. The big one for also aneurysm. If the left ventricle aneurysms out and becomes really big, we can see characteristic signs of that on the EKG. The big one that I was looking for was heart attack. We see this classic, I don't know if you guys have heard people call something a STEMI, but that's an ST elevation MI. And that means that when you're having a heart attack, and because these are actually grouped regionally, 2, 3, and AVF, these represent the backside of the heart. 1, 2, 3, 4, 5, 6 are leads. These V1, 2, 3, 4, 5, 6 are all kind of in a line across your chest from the right to the left. And so this is looking at the heart kind of like if I were to slice you kind of in half, like through your trunk, like horizontally, these would kind of cut a line through the heart that way. So this is looking from right to left. And then these guys look at kind of the front of the heart along with some of these. And so based on where we see those ST elevations, this being the S and this being the T here, these will tombstone up and look quite large. And based on where we see those elevations, we can actually tell which vessel in the heart has a clot. And so we can kind of localize it based on the EKG. So that's the big one that we do if those troponins, like we looked at earlier, were, say, really elevated. But anybody with a cardiac story is going to get an EKG. If I'm getting like too into the weeds about this, just tell me to move on. But I think that this is cool and it's good for you guys to know too. We said chest x-ray. This guy came in through the emergency room, which means he got a chest x-ray, of course. I'm not trying to be mean to the ED people, but we have, you know, internal medicine and emergency medicine people classically feud with one another. So I'm looking at this chest x-ray. Again, I don't expect you guys to know how to read a chest x-ray, but any notes you guys want to make? Do we see any consolidations? Does the size of the heart look appropriate? Any notes anybody wants to make about this chest x-ray? Anyone? Heart looks swollen. Yeah, I would say that this is a big heart. It should usually be, I think it's a third of the width of the chest about. And so this is a huge heart. It's quite big. So it can be big because it's kind of like dilating and all the chambers are large. It can be large because a frightening reason for it to be large was we talked about that pericardial sac that's around the heart can actually fill with blood or fluid. So it like makes the heart look like it's big, but really it's that sac that's stretching out. And that's a condition called cardiac tamponade, which is quite scary. And will often actually they'll need to go in through the chest wall and drain that fluid out or that blood out, which is a big problem. So he doesn't seem unstable enough for it to be like a tamponade picture, but definitely this heart looks big, which would be a concerning thing. Other things that we'd look for when you go through how to read EKGs, when you go through how to read chest x-rays, you'll learn the ABCDs. A is airway, so we're looking at the trachea, making sure it's midline, looks midline. B, bones. I don't see any fractures. C, cardiac. Okay, heart looks kind of big. D, diaphragm. So this is the diaphragm down here. We like to see nice sharp angles where the diaphragm meets the side of the chest wall. I don't actually see those, so it could mean that he has some fluid kind of collecting down here because gravity dictates that fluid goes kind of to the bottom. So if he had any fluid in the lungs, we wouldn't see that nice sharp definition here, which is kind of, we don't see any nice sharp definition here. So, and then E, I don't remember what E is. And then we also were looking for like lines or drains or anything. If he had a pacemaker or something, we would see that here too. Okay, Now that we have some more data, we've looked at the EKG, we've looked at the chest x-ray, we had some labs. How does this change our differential? What do we think is most likely other than endocarditis? Kind of infection. Yeah, I agree. The white blood cell count is pretty concerning. The chest x-ray didn't look like pneumonia, but I mean, with the oxygen requirement, I would still probably keep it on my differential. White blood cell count doesn't really explain heart failure. I think that this looks very much like a heart failure picture if you take those white blood cell count away from it and the fever. So I think heart failure is probably a component of his picture, but then we are like, he's probably got an infection too, so what would the source be? So that's kind of like two different things in one. We did this. Oh, I knew I was going to confuse myself with my own slides. So hooray, we've been looking at this case for long enough that some of the blood cultures have resulted. The blood cultures are growing Staph aureus. This for us, or this for me, was kind of a slam dunk. I was like, I think I know where this is coming from. And we're going to go through why, and then you will know why. Coming up next. Someone said we're going to get an echocardiogram. That is exactly what we did. We wanted to get an echocardiogram to see if the source could be vegetation on the valve, especially with that Staph aureus growing in the blood. So we're looking at the heart kind of upside down right now. This is the left. So the heart has 4 chambers, 2 ventricles and 2 atria. There's the left ventricle, which is kind of like the big mama ventricle that pumps all the blood out into the body. This is the left atrium. This is the right side of the heart. This is like the drainage side of the heart, where the blood, the deoxygenated blood kind of comes back in from the body and then gets pumped out into the lungs. So the deoxygenated blood will come from the body into this right atria, will go down into the right ventricle, and then will pump into the lungs. And then it will come back from the lungs into the left atria, down into the left ventricle, and then the big left ventricle is going to pump everything out into the body. So this is our lower pressure side of the heart here. The tricuspid valve connects the right side of the heart together, and the mitral valve connects the left side of the heart together. We don't see the aortic and the pulmonic valve pictured here. So which valve do we see some vegetation on? Right ventricle. Yeah, this tricuspid valve right here, it should look nice and clean like a line here. It has all this junk on it. So this looks like endocarditis to me. So now I'm writing my note. It's the end of the day. I want to go home. So I'm typing up my assessment and plan. 43-year-old male. I think he was 41 before. He wasn't here for 2 years. I'm just making a mistake. 43-year-old male, past medical history significant for substance abuse disorder, IV heroin, presenting with SIRS positive sepsis, SIRS being a criteria we use to determine how, like, if someone is actively infected and with unstable vital signs. In the setting of, is what this means. I shouldn't have shorthanded it. I'm sorry. Staph aureus bacteremia and new tricuspid valve vegetation consistent with bacterial endocarditis. So the plan, I'm going to start some antibiotics for him. I'm going to get an even more detailed echocardiogram called a TEE, which I'll talk about in a second. And I'm going to consult infectious disease because I'm weak and I want the infectious specialist to double check me and make sure that I gave the right antibiotics. It's important to know when to consult your specialist, and I definitely consult my specialist. The TEE is different from the TTE in that the TTE is transthoracic, so it's that one where they're on the outside of the chest. The TEE is transesophageal, so they actually put a tube down the esophagus because the esophagus sits like right behind the heart in the chest cavity, going down into the stomach. And they actually put a little ultrasound at the end of that probe. So you're obviously sedated for this. And then they can kind of do the echocardiogram from the back side of the heart where you're much, much closer than if you went through the chest wall. And that's actually the best study to look at the valves because you're way up close to them. So I would have gotten that as well to get a better look at those vegetations. Okay. Any questions about the case before we move into talking about endocarditis itself? No. All right, we're going to move on. All right, so endocarditis. It's inflammation of the endothelium of the heart or the heart valves, which is what this guy had. Who gets it? People with any disease or damage to the heart, especially people with prosthetic valves, people who've used IV drugs, people who are immunocompromised, people who have poor oral hygiene or maybe like had a dental procedure recently, because the gums are really vascular. So classically, like that's why looking in people's mouth when you do your physical exam is actually really important. I'll often note if their dentition is good or poor, because that will that puts those people at higher risk for infections, especially to the heart. The IV drug use thing is interesting because when you're injecting directly into the bloodstream, the thing that filters out all of the blood is going to be the heart. So it's going to hit the heart valves. And because we talked about how the right side of the heart and the left side of the heart are like one is a high pressure system, the left side, and the right is a low pressure side. Because at low pressure side, because it's draining all the deoxygenated blood from the body, because it's so low pressure, any bacteria that's being like injected kind of alongside the drugs when you're when you're injecting into the body will kind of stick to the valves and cause vegetation there. So classically, these people who use IV drugs will develop vegetation on that low pressure right side of the heart, the tricuspid valve, which is what he had. But interestingly, the most commonly affected valve is actually the other valve, the mitral valve on the left side. But if you were an IV drug user, then it's actually more likely to be the right side. I don't know if I made that confusing, but basically in most people, it will happen on the left because most people are not IV drug users. But then IV drug users, just because they're directly injecting into the heart, not into the heart, because they're directly injecting it into the body, it will stick to that low pressure system rather than it coming like from somewhere inside the body. Like the dental procedure guy will get it on the mitral valve, if that makes sense. These screenshots are going to be from one of my favorite resources, Amboss, which I highly recommend, non-spawn, but if they sponsor me, that would be great. So pathology for endocarditis, we see fever and chills like we saw in him. He looks severely infected. He's tachycardic. He's got malaise, which is basically meaning he just looks really run down. He's kind of weak. Sometimes we even see weight loss and night sweats. We might have some muscle aches, joint pains. Looks kind of like a flu for a lot of people. And we see acute signs of sepsis like we saw in him. Some clinical manifestations, also things that we saw in him would be new valve murmur, like we saw, heart failure symptoms, which we also saw, and sometimes we even see arrhythmia. We didn't see that on his EKG. This is just to reinforce that anatomy we talked about before. Again, we have blood coming in from the lungs down this tricuspid valve, which is where his vegetation was, and then it would pump back out into the lungs to retrieve oxygen. And then there are 4 little veins here that come back from the lungs with oxygenated blood that comes down through the mitral valve, and then it will be pumped out this big aorta up here to go out to the rest of the body. These are some cool physical exam findings, which you would definitely see in an exam when you're studying for steps and things. So these are some classic lesions that we see. We use the mnemonic from Jane for these. And basically, the pathophysiology for all of these things is the same. The Roth spots, the Janeway lesions, the Osler nodes. It's that we have this thing sitting on the low pressure side of the heart, the right ventricle, on that tricuspid valve. And little pieces of that clot, really, that's forming there, that vegetation, can break off and will deposit into the eyes, as we see here, into the skin. And so we kind of classically see these like spots basically of immune complex, of hemorrhage, kind of building up in other places of the body that are like shedding off of that vegetation, which is pretty crazy. Can even cause stroke-like symptoms, as you can see down here. So we use this thing called the Duke criteria, because Duke is one of the major cardiac hospitals in the country. So they made this fancy criteria and they got to name it after themselves. That helps us to determine the likelihood. In medicine, we have scoring systems and criteria for everything. So in order to kind of start like going through the Duke criteria and calculating if it's likely to be endocarditis or not, we're going to draw 3 sets of blood cultures. We like to get multiple blood cultures because it's kind of like if only one is positive, then oh, it could be a contaminant. But if all 3 are positive, then oh, that's definitely coming from the blood. So we like to get a few. Chat. Is there a chat that I'm missing? Oh, somebody left. Sorry. Okay. So here's the modified Duke criteria. We like to see positive blood cultures growing one of these things. Common one here is Staph aureus, like we saw already. And then some of we see, so it's basically positive blood cultures. We see it on the echocardiogram, which we did for him. We got the positive blood culture, and he had new valvular regurgitation, that murmur that we heard. And so he actually hit all 3 of the Duke criteria. So this is a slam dunk. Minor criteria being immunologic phenomena, vascular abnormalities. So that might be some of those like Janeway lesions and things, and being feverish, which he did have. So like his IV drug use is technically not a major criteria. Again, we do a TTE, this transthoracic echocardiogram, which looks like this. This is a mitral valve here on the left side of the heart vegetation. And this is that TEE where we kind of put them to sleep and we thread this down and we look at the heart from the backside here. TEE is a much better imaging study for this, as I said before. And then we start these people in antibiotics, even if we're still waiting for the blood cultures to come back, say, because sometimes they take a couple of days. We will start these people right on broad spectrum, hard-hitting antibiotics right away. I consult infectious disease to make sure that they don't have something else specific that they want to do for us. And then they actually have to be on antibiotics for quite a long time, the metric being like months. And for some people, if it's like, say they had a prosthetic valve, because again, damaged valves or hardware, different valves, valve replacements, are more likely to grow these vegetations just because it's kind of like a foreign anatomy. So if say someone's prosthetic valve has endocarditis on it, they will actually have to consult cardiac surgery, and we would have to probably have that valve removed. So that's my whole shtick about endocarditis. I hope that you guys learned something. I'm interested in cardiology, so that's kind of why I wanted to talk about this today. Does anyone have any questions about med school, residency, cardiology, endocarditis, anything I can go over? Thank you all for coming and spending your evening with me. How much shadowing do you suggest we do as pre-med students? Yeah, that's a really great question. I would say do as much shadowing as you're able to reasonably do. Med schools definitely like to see that you have clinical exposure to kind of back your interest in medicine. Something that I recommend for a lot of people. Oh, thank you, Maya. Something that I recommend for a lot of people is if you can to do something like scribing instead, because you still would get the clinical experience, but you're taking kind of a more active role on the clinical team and you're also learning more terminology. So in general, if you can, I'd recommend trying to scribe or like maybe do EMS or something like that to like emergency medical services to try to take a more active role in the team and learn some terminology, kind of get some more hands-on skills. But I would try to shadow as much as you reasonably can. Find a good physician who, or even a medical assistant, but you'll want to work with a physician as well if you're applying to medical school. Ideally someone who might be willing to write you a letter. And it doesn't matter what specialty they're in either, because it's really, medical schools won't really care much about, oh, it's all in neurosurgery, but I all my shadowing is in neurosurgery, but I think I want to do pediatrics. They wouldn't care about something like that. So really just try to sometimes you have to just cold call or email a clinic and see if someone would be willing to let you shadow them. And in general, a lot of physicians don't mind. Um, yeah, it was really tough. So in medical school, my medical school was structured with the first 2 years were a lot of textbook learning, and the second 2 years were more our clinical rotations, and we were just at the tail end of COVID. It was really tough. A lot of us use this flashcard system called Anki. I don't know if you guys use it. Maybe I'm aging myself, but I didn't know what Anki was. And there are these great decks of thousands of cards that people have kindly put together that many medical students use. There's a lot of video resources. I think most of the people in my class studied by video. We use this thing called SketchyMed, which like teaches you the different antibiotics and things. And Pathoma, Boards and Beyond were kind of the big three that we used. And many of us would supplement our lecture learning with videos. But it was really tough. I mean, it's a full-time job. I was doing this as well, kind of on the side, but most people don't. Most people don't kind of do other things on the side of medical school because it really is pretty difficult. Be prepared to say no to a lot of social engagements. Thanks, Mohammed. Any more questions? I'm happy to stay on. Yeah, of course. Happy to teach. I love doing these things.